How do we evaluate somebody? For a multidisciplinary clinic, where we have the physician, the advanced practice provider, the physical therapist, the social worker, and the pharmacist all working together to come up with a plan to improve balance and stability and decrease falls. How do we do that in the clinic? We were lucky enough to have the pharmacist to help review the medicines and to get the history. It's so important to have them tell you about their most recent falls. Ask what happened in their most recent fall. Were they dizzy or lightheaded? Did they have palpitations or a racing heart? Did they have shortness of breath or chest pain? Were they shaky or jittery? Did they just stand up or had they been standing for a long time? Did they remember tripping? Did they remember the whole thing, or did they lose consciousness? Was it actually a syncopal episode? On examination of somebody who comes in with the fall, you have to check vision, whether it's a selling card or you're doing the E across the room. You have to check out their vision. Ask about cataracts or other problems with their vision. Even ask about if they have nice smooth glasses. Do they have bifocals or trifocals? That can certainly become an issue as we get older. The brain is just not fast enough to switch between where you're looking at and your processing of what you're seeing. Check orthostatic blood pressures. It's important to have some other test of balance, whether it's quick and in your office. Just the act of standing from their chair. Can they stand up from their chair without using their arms to push off? That tells you something. There are certainly lots of studies and evaluation done on the TUG, the timed up and go test. The physical therapists do a huge battery, which can be the Berg balance, which gives you a nice score for fall risk. You can simply do the progressive Romberg, so standing eyes open with your feet together, and then your eyes closed, feet together, and then semi-tandem. So one foot is slightly in front of the other, eyes open and eyes closed, and then the full tandem with eyes open and eyes closed. That's the progressive ROM. Can they fall or do they have to step out? That's a score out of 6. So if they can complete all those, maintain their balance without stepping out with eyes open and eyes closed, that's a score of 6 out of 6. Take away the things that they can't do. You need to assess their strength. Their vibration stems their fine sensation in their feet. Do they have a tremor? A resting pill rolling tremor? Do they have Parkinson's disease? Are they more rigid? Do they have bradykinesia? All things that need to be evaluated. Do they have swelling in their legs? You have to look at their history. Not only the history of their fall, but their past medical history. Do they have diabetes? Are they more likely to have peripheral neuropathy? Do they have joint issues with hip, leg, knee pain, osteoarthritis, low back pain, and other things? Evaluate their gait. Do they have a wide base gait? Do they have an antalgic gait where they're limping? Do they have laxity in their joints? Do they have shuffling gaits and don't have a good nice high step? All those things you can evaluate along with a physical therapist or on your own to get an idea of what's going on. With Parkinson's, do they have flat effect? Do they have hunched posture? Short shuffling gait with the fenestrated terms and lack of arm swing? Those are all things to be aware of as you're evaluating somebody who's coming in for falls. Look at lab tests. Make sure that in the last 6 months, they've had a complete blood count. Do they have an infection that we're not aware of? With an elevated white count, do they have anemia that's contributing to dizziness, orthostasis, and fatigue? Do they have hyponatremia or chronic kidney disease? Do they have good potassium levels? What's their thyroid level doing? That can be one of the first signs of hypo or hyperthyroidism. Vitamin D deficiency is certainly essential to treat a deficiency. Sometimes we get B deficiency affecting our peripheral neuropathy, our strength, and our movement. In labs, a normal B12 goes down to 200, but always treat a B12 level less than 400. If the methylonic acid is high, then your B12 is low. With imaging, rarely do we get X-rays or MRIs of the brain or the spine if there's spinal stenosis or other things that maybe weren't such a thing, but very rarely do we need something like that. Make sure that they have an up-to-date DEXA scan because it's important to these people that we're treating and preventing fractures. Make sure we are on a treatment for osteopenia with a high FRAX score or osteoporosis. It's so important in our balance and stability. Ask about their diet. Often, in our older adults, they have tea and toast. They aren't putting in the effort to make a full, well-balanced meal, or because of swallowing or chewing difficulty with dentures and teeth, they're not doing meats anymore, and they aren't aware of other ways to get their protein necessarily. Older adults actually require much more than a younger adult to maintain their fat-free muscle mass. A 20-year-old needs 1 gram per kilogram of protein to maintain their muscle mass, and an older adult needs 1.5 grams per kilogram. That's to maintain their current muscle mass. If they are needing to build it, then they need that much more. That's a lot of protein. Finding ways to help your patients get that extra protein in their diet is essential. The SARC is a way to assess a muscle weakness. Muscle atrophy sarcopenia is the term for that, and it's important to know the term sarcopenia, because often if you're trying to get home health, PT, and OT into the home for home health care, Medicare will not accept weakness as a diagnosis to cover, but they will accept sarcopenia, which is just a fancy word that basically means the same thing. Here's the St. Louis University Stark screening for sarcopenia, which is loss of muscle mass. It's weakness and loss of muscle mass. These are typical questions to assess that. You can get a gist of this just in evaluating the patient, but this is another way to help determine if they have loss of muscle that's contributing to their balance, stability, and their increased risk for falls. How much difficulty do they have in lifting and carrying 10 pounds? Do they have difficulty walking across the room? How much difficulty do they have transferring from a bed or a chair? How much difficulty do they have climbing a flight of 10 stairs? How many times have they fallen in the last year? You can say total score of 4 or more indicates sarcopenia. As mentioned before, that can be a Medicare covering diagnosis for home health. There's different ways to measure fall risk. We're trying to catch people before they fall. So who's at risk for falling even though they haven't fallen yet? How can we catch them early enough that we can intervene and prevent them from becoming fallers? There are several ways to do that, but the one that we're evaluating right now in our clinic is gait speed. This has been a well-studied evaluation of balance, fall risk, and the ability to do activities of daily living. To require a higher level of care has been teased out with various studies. What is gait speed? It's timing their walking. You time them for the 5 meters, and then assessing meters per second. How fast can they go? Begin the test at a starting mark with another mark indicating the goal. Make a mark where you will start the timing, and another mark to stop timing, with a deceleration phase afterwards. Allow some room for acceleration and deceleration, and time in the middle. Do at least 2 of these trials. Time them both and take the average. Try to do this once a year, or repeat if there is a huge change in their health. A good cutoff for walking speed is 1 meter per second. If someone's walking speed on average is 1 meter per second or faster, they are less likely to be falling, hospitalized, and more likely to be independent in their activities of daily living. They can do lots of household activities. They're independent in their self-care. If somebody is greater than 1 meter per second, they're doing great and recommend they continue their regular maintenance and exercising. If someone's coming into the clinic and they're 0.8 meters per second to 1 meter per second, then prescribe them an exercise program. The National Institute for Health on Aging has really good packets and videos. You can get the packets for free if you go to the NIH website and have them mailed to you. They have several different good pamphlets and videos on exercising. If they are 0.6 to 0.8, they will need physical therapy for balance and strength training. If they're less than 0.6, generate a referral to the balance of stability of the clinic to see if there's anything else we can do where we all work together. As you can see, the slower you get, the more likely you are to be at risk to fall, to have to go to a hospital or to a nursing home, and after hospitalization, mortality. Very interesting work has been done with walking and gait speed. Try to use that as a way to intervene before somebody falls. Other ways you could do that are validated. The timed up and go test, which is a similar thing used to having somebody sit in the chair, stand up, walk 10 feet, turn around, and go sit back down. You're timing them. If an older adult takes greater than 12 seconds to complete the tug, they are at risk for falling. You can find more information for this at the CDC. There's a study program. Here's our second polling question. What is the cutoff time on the timed up and go tug test that indicates an older adult is at risk for falling? A. Less than 8 seconds. B. Greater than 12 seconds. C. Exactly 10 seconds. Or D. Greater than 20 seconds. The correct answer is B. Greater than 12 seconds. Those are just a few you can do. Stand-up sit-downs, or just have them stand up from their chair. If they can't stand up on the first try without the use of their arms, then they're at risk for falling. What do we do if somebody is falling? If we've evaluated them, what can we do? From multiple studies, you can prescribe exercise, and you get results if you can engage these people and get them to do it. Exercise is important. Exercise has been studied, validated, and proven. You particularly need balance and strength training, as well as gait training. Flexibility is important too. High-intensity interval training is important. With strength training, there's kind of a dual task training, where you are walking and talking or having to count backwards. That's important because multitasking and getting your brain to do multiple things at once helps with processing speed. There's balance perturbation, where the physical therapists almost instigate the fall and see how you catch yourself. They help teach and train you to catch yourself. All those things are validated and proven. We need to take a look at their medication lists and minimize those medications that we know are dangerous and likely to be causing trouble. We need to de-escalate medications that are causing low blood sugars or hypotension, and we need to try to deprescribe so that the patient is only on the important medications. Get rid of unnecessary medications and avoid prescribing cascades. Manage postural hypotension. If medications aren't contributing, then what can we do? As a last case scenario, they need midodrine, but can you increase the salt intake in the morning? Or increase their fluids? Most likely, they're dehydrated, so contribute to hydration. Fill up a bottle and sit it at your favorite chair. It has to be done by 3 in the afternoon. Have sticky notes reminders to tell you to drink. Also, manage foot problems. Talk to them about their footwear. They don't need to be wearing high heel shoes. They should be tied or cover the heel. If it's a slip-on, it has to cover the heel. Nice, secure, and stable shoes, as well as tennis shoes. Supplement their vitamin D. Treat vision impairment. Get that cataract surgery if you need it. Change from trifocals or bifocals to monocular glasses. Have the readers for when you're sitting down. Our brain loses the ability to make that change fast enough and can contribute to falls. Manage heart rate and rhythm abnormalities. If you know if they're going into a fib with RVR, and that's what's causing it, and treat that. Modify your home environment. Occupational therapy will go into the home and do safety evaluations. They'll talk about clutter, rugs, lighting, nightlights, handlebars, not using step stools, but using extension grabbers. All those good things to help keep us safe in our home. That's a quick overview of how we manage to try to prevent falls, to evaluate somebody at risk for falling, as well as how we treat them at our balance and stability clinic. This is one case that is very typical of what we see at our balance and stability clinic. This is an 83-year-old white female with a history of hypertension and osteoarthritis. She has had a history of total hip arthroplasty and total knee. She has diabetes and congestive heart failure. She presents having 2 falls in the last 3 months. Recently, she was seen about 2 months ago with a congestive heart failure exacerbation and Lasix, and our ACE inhibitor and choring her lisinopril and Cori were titrated for improved symptoms, which she reports she's had improved shortness of breath and edema. She describes dizziness often with standing and falls occurred when rushing to get to the phone and to the bathroom at night. Those were the 2 times she did not have racing harder palpitations, chest pain, etc. When she fell, her vital signs were taken in the clinic. Her pulse was 62. Blood pressure was nice, 125/72. Respiration was 16 on room air. When we checked her orthostatic blood pressures on standing, her blood pressure dropped to 98/58 with a pulse of 78. We reviewed her medications. We asked them to bring everything they take in on a regular basis, even over the counters, and then her nice big bag. She did have a bottle of Tylenol PM, which she had just started taking because of difficulty sleeping. She has poor vision, and she notes that she's been told maybe she needs to get a cataract removed, but she's been putting that off. It didn't seem like the right time to do that on exam. She had decreased vibration sense, consistent with the diabetic peripheral neuropathy that she likely has. She has stiffness with standing, requiring the use of her arms. Heart was regular. Lungs were clear. She did have a B12 deficiency, although it's considered in the normal range on our lab. Her creatinine was slightly up, consistent with the dehydration and chronic kidney disease, likely from her diabetes and hypertension. This is a typical lady. Her falls are multifactorial, related to weakness, deconditioning, orthostatic hypotension, B deficiency with diabetic peripheral neuropathy, and medication side effects, along with poor vision. If you can encourage physical therapy and exercise, strengthening, balance training, recommend that you go for that cataract removal to improve her sense of vision, decrease that Lasix dose because she is dehydrated, and we probably ramped that up too much when she was in congestive heart failure exacerbation. We can back off on that and really watch, but get her blood pressure when she's standing. Have her drink lots of water throughout the day. Give her some to replace that most of the time. You can get by with oral 1,000 micrograms daily. Very rarely do I have to give B12 to get somebody replenished, and make sure she's aware that Benadryl is not a good idea. Talk about sleep hygiene. The safest thing if you have to do something besides sleep hygiene would be melatonin over the counter. So certainly not anything over the counter with a PM because it has Benadryl in it. Melatonin is okay. That is a typical person we see, very multifactorial. If you chip away at those little things, you do improve, and you have people who come back not falling, and you strengthen them or decrease their fear of falling, and get them back out moving in community, therefore decreasing their isolation and improving their cognitive and socialization in the community, which improves their mobility, morbidity, and mortality. All these things are important. If there are any questions or concerns, don't hesitate to reach out to me. It was a pleasure talking to you about mobility today. Thank you.